Um, I was given a series of neonatal congenital heart disease diagnoses. But I think this is definitely a great educational forum. We have to, as much as we can, try to make it relevant to the curriculum and appropriate for the current level of training. So these topics are huge topics. They have a lot of um, details that we can cover. We can probably dedicate a series of multiple lectures to each diagnosis, but we'll try to make it simple and try to make it, say, congenital heart disease 101, so to speak. If you think I'm going too fast or I'm not clear, just stop me at any time and let me know, okay? So, dextrotransposition of the great arteries is, according to some references, the most common form of cyanotic congenital heart disease in neonates. And the reason they're cyanotic is not because there is underperfusion to the lungs, but because the systematic and pulmonary circulations are in parallel with very little or no mixing sometimes. And the main feature of the disease is ventriculo-arterial discordance. So the subpulmonary ventricle gives rise to the pulmonary artery, and the subsystemic ventricle gives rise to the aorta. So the blue blood keeps going to the aorta and back to the right ventricle, and the oxygenated blood goes to the lungs and back to the pulmonary veins to the left ventricle and out to the lungs again. And the severity of cyanosis depends on the level of mixing and the amount of mixing. Babies who have adequate mixing cannot manifest severe symptoms and are quite often discharged home after delivery. While on the other hand, you might have a neonate crashing because of hypoxemia and severe acidosis in the first few hours after birth. So it's a spectrum of disease. Really what makes them survive the initial few days after birth is the presence of mixing and the extent of mixing. Okay. So this is just a diagram of normal circulation and in parallel circulation. You see the vena cava blood back to the right atrium, the right ventricle, and the aorta, and it just keeps going in that circle. And on the other hand, in the pulmonary circulation, again, pulmonary vein to pulmonary artery, and keeps going in that circle. What are the sources of mixing? The best source for mixing is an ASD or a good size PFO between the atria that allows for mixing of the oxygenated blood with the deoxygenated blood. Therefore, the systemic circulation gets some oxygen. And a lot of these neonates can sat up in the 80s if the ASD is big enough. The second level for mixing is the VSD. And the VSD in general is not a good mixing site because in systole, whatever blood is coming out of the VSD usually goes to the nearby trunk. So it doesn't really mix that well, especially in diastole. And quite often, even in the presence of a good sized VSDs, these patients can be quite cyanotic. The PDA is another site for mixing, and a lot of these patients are kept on prostaglandin post-birth, especially in remote hospitals, to allow for some degree of mixing until they're transferred to the treating hospital. If I had to give them a sequence in best to worst, I think I would give a good size ASD number one as the best source for mixing, followed by a PDA, followed by a VSD. I don't know why I wrote it in this order. It should be ASD, PDA, probably in VSD. How can we improve mixing if the baby is not born in a center where the problem can be addressed definitively? There are a number of measures that can be taken to improve the oxygen saturation and improve the chance of this baby getting to a center where they can receive treatment. Prostaglandin is a mainstay in cyanotic babies. You don't even have to know the diagnosis. If you have a cyanotic baby, most places just start prostaglandin without a clear anatomic diagnosis, because it's either a systemic or a pulmonary ductal dependent circulation. And in case of TGA, it improves mixing. So really there is not a lot of harm. Some babies have to be intubated to be on the proper dose of prostaglandin, but that's something that most hospitals that give birth to babies can handle. Atrial septostomy is a well-known procedure, a temporizing procedure to increase the size of the PFO or the ASD. It's either done under ultrasonic echo guidance or in the cath lab. Most hospitals with a cath lab facility probably don't need to go to a septostomy, except if the baby is too septic or too sick to undergo surgery, then it can be used as a temporizing measure. PDA stenting is a relatively newer concept in TGA. Not only that it improves mixing, but it also subjects the future systemic ventricle to higher pressure, meaning that it can be used if the anatomical repair is expected to be delayed to protect the left ventricle from quick deconditioning. And I will touch on that in a minute. So when the babies are born, the systemic vascular resistance and pulmonary vascular resistance are almost equal, and both ventricles are subjected to the same resistance or pressure. After birth, shortly, in the first 2 weeks or so, the PVR drops to near normal levels, which is less than a third of that of the systemic vascular resistance. Therefore, the left ventricle becomes subjected to lower pressure circulation and loses some of its mass and strength. So when you ask the systemic ventricle after a period of deconditioning to become the systemic ventricle again, supporting the aorta and the systemic circulation, it might not do well if it has been deconditioned for too long. What are the options for dextrotransposition of the great arteries? For the sake of probably completion, I'm going to mention all of these. And after that, we're only going to talk about the arterial switch operation today. So historically, the first operation that was offered is the atrial switch operation. And the two main versions are the Senning and the Mustard. Senning was from Austria, and Mustard was in Toronto. And that was the mainstay for a while, for almost 2 decades, because no one could successfully switch the coronaries without and ending up with a living patient. The arterial switch in the early 80s became the standard of care. There was a lot of experimentation on the arterial switch in animals and in autopsy samples. And early in the 80s, a number of groups could perform it on living babies with good results. And again, we will touch on that more. If TGA is not the only problem, meaning if there is any other defects or associated problems, like coarctation of the aorta or complete AV canal or some form of left ventricular outflow tract obstruction that can be relieved prior to the arterial switch operation, these can all be concomitant procedures that are necessary at the time of the arterial switch. Ventricular switch is a term used when you cannot use the systemic outflow tract. You cannot rehabilitate it or repair it in a way so that it can support the systemic circulation. Therefore, you have to divert that and let the VSD kind of act as an outflow tract, as a systemic outflow tract. And there are different ways described to do this. The most classic one is a Rastelli operation. REV is a French conduit-less repair with no valve. And the Nikaido operation, which is the aortic translocation. Again, it serves the same purpose as the Rastelli and the Rev, and you can either do it with a conduit or without a conduit to the RV, from the RV to the PA connection. So what about timing? I think this is a fair game for questions in terms of exams and oral exams. Timing of repair for d-TGA varies according to the associated problems. If it's only a TGA with intact septum, then it should be probably corrected in the first 2 weeks of life because of the deconditioning that we talked about. If the left ventricle is subjected to pulmonary vascular resistance for too long, it becomes too weak to support the systemic circulation. So then you might have to do surgical training or use temporary assist devices to support that ventricle after the repair. If there is an associated VSD, then probably you can delay the repair, the initial repair, for up to 2 months of life, but not much later than that because these patients are at an accelerated risk of developing pulmonary vascular disease. Usually, if it's just a VSD with overcirculation, that takes longer to develop. But if the pulmonary vasculature is subjected to fully saturated blood for too long, then that accelerates the risk, along with the volume overload, that accelerates the risk of developing pulmonary vascular disease and some degree of irreversible pulmonary hypertension, even if you do the repair. And it's not uncommon for d-TGA with a large VSD to have irreversible degree of pulmonary hypertension, even if repaired at 6 or 8 months of age. So preferably you don't want to wait that long, and you want to do it in the first 2 months of life. For the ventricular switch, usually there is enough obstruction in the left ventricular outflow tract to protect the lungs, and you can delay that to an age where you usually do complete repairs for tetralogies of Fallot, which is around 4 to 6 months. The coronary anatomy, you'll find a lot of different diagrams described by a lot of different groups, the Boston group, Yacoub and Bradley Smith, and several modifications of both, depending on which textbook you look at. I find the most useful one is the one that mentions which artery comes from which sinus. So there's sinus 1 and sinus 2. And then you describe the pattern of branching depending on which coronary comes out of which sinus. And again, these are good to know for understanding the variety of coronary arrangements in the TGA. But nowadays, almost all of these arrangements can be treated with arterial switch. But you might have to do a little bit of something extra to address this variety. But I don't think that in the modern practice, any of these arrangements is a contraindication for arterial switch. Maybe the one rare exception is when you have an intramural segment that is long enough to preclude its complete mobilization between the two trunks. But again, this is not for this presentation or for um, the residency uh, level of congenital heart disease that you're expected to know. So if you want to read more about that, we can do that in the discussion, or I can point you to some references to look that up. I have to mention this because I found it quite interesting that Dr. Farouk Idris, who used to practice in Chicago in the 60s, he was the chair of the program from mid 60s to I think late 80s. And he did a lot of work experimenting on transposition. And he tried to devise multiple operations doing coronary relocation or translocation on dog models. And I think his work, along with Maurice Lev, who was the pathologist at that time, who described all of the autopsy samples, um, did not get enough credit historically. And I got a chance to learn that bit of history when I was in Chicago. And you'll find that some of his publications, like this one, dates back to 1961, which is almost 20 years before the successful arterial switch operation was reported. And what they did in this operation is that they translocated the coronaries as one ring as opposed to separate buttons the way we do it now. And it just tells you that a lot of these surgeons, in spite of the limited resources they had at the time, were quite creative in trying to come up with solutions that we now take for granted in the modern day practice. This is just a completion of the operation in a dog model. And most of these dogs came off pump fine, but of course, because now they end up with hypoxic circulation, they did not last much longer after that because they didn't have d-TGA to start with. But it was just a proof of concept. And this was his publication in 82, describing their first 50 patients of arterial switch in an infant. And they basically classified it to the four main steps of an arterial switch operation. And that includes the Lecomte maneuver that we'll talk about in a bit. But of course, the first publication was by Adib Jatini from Brazil. He published the first report of a neonate who underwent arterial switch and survived. Shortly after, the group in London, Dr. Yacoub and Bradley Smith, followed with another report. And after that, most of the busy neonatal units started adopting arterial switch operation by 1982-3. And we started seeing a large number of series, and it started becoming the favorite operation in the community of congenital heart disease for the transposition of the great arteries. This is just a cartoon of the Rastelli operation. The native or subpulmonary or LVOT is narrow, and you cannot use it and in a switch operation. So what you do is that you tunnel the VSD to the aorta, and then that becomes your new LVOT, and use a conduit or not to reestablish RV to PA continuity. And this is a REV procedure utilizing the Lecomte maneuver to bring the bifurcation directly to the right ventricle with no valve. And the Nikaido involves translocating the aortic root posteriorly to maintain better alignment for an LVOT. And then the RV to PA continuity can be established with or without a conduit. So I'm going to stop now for a few minutes and see if you guys have any questions. Who's moderating this session?
Yes, I am moderating this session.
Are you ready to find out, or should I carry on and leave the questions to the end?
Shabab, any questions at this point of the lecture? I have a question about the. I have a question about the d-TGA with the VSD. So as I understand it, the shunt will be left to right, or from the sub arterial subaortic ventricle to the subpulmonic ventricle during systole. Is that right?
Right.
Yeah. So for those patients, they will be a bit more hypoxic than patients without a VSD.
Yeah. The longer they,
yeah.
Of course, beginning the pressure is almost equal, and if the VSD is large enough, then you basically end up with pressure equalization in both ventricles. That's why it's not thought to be a great source for mixing. But did I answer your question, or?
Yeah, but the reason that we can wait for them more is that the future systemic ventricle is subjected to the systemic pressure, so that's why the deconditioning is less on those subset of patients. Correct?
Yes, yes, absolutely. But the reason you should not wait too long, like any other VSD that undergoes elective repair, is because of the high VO2 in the pulmonary circulation. That leads to accelerated development of pulmonary vascular resistance or pulmonary vascular disease. So, like I said, from my own experience, we had a couple of patients who were referred after 1 year of age for complete repair. One of them was misdiagnosed as a VSD without realizing that he had a d-TGA. And both underwent repair and both have residual pulmonary hypertension. One of them is near systemic. This is now 4 years out of the operation, and he still has near systemic pulmonary hypertension. So these patients, if you wait on them for too long, even you can get them through a switch operation with a VSD closure, but they may not recover their pulmonary vascular disease.
That's clear.
That's why we don't wait too long on them. As a matter of fact, nowadays, if a patient is born in hospital with a diagnosis of d-TGA VSD, they don't leave the hospital before they get corrected. We don't. Okay.
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 So, Dr. Mohammed, can I ask, please?
Yes, please.
What's the percentage of coronary artery injury in this operation, and what's the solution if it's happened?
Coronary artery, what? Sorry?
Coronary artery injury. And
right.
If I injure the coronary artery, what should I do?
Yeah. Well, it's not good. I guess you should try to avoid that. To be honest, if the injury is in the button or the proximal part of the ostium, you can probably find a way to salvage that. If the problem is due to a kink after the anastomosis, you can probably revise that. But if there is any serious damage to the left coronary especially, then that's almost a guaranteed low cardiac output / mortality after the procedure. And this is why this procedure took a long time to develop, because surgeons needed to, get used to dealing with the coronaries in that small size and learn all the, sometimes it's a millimeter difference between a perfect anastomosis and a kinked anastomosis. I mean, you try everything you have to bail yourself out when you get into trouble, But honestly, in that age and weight, there's very little you can do in terms of coronary bypass, for example, or, I mean, I'm aware of a few neonatal reports where they used Lima anastomosis to the LAD. I guess it's doable, but it's definitely without, not without major risks and complications. So yeah, so the best thing is not to get the coronaries injured from the beginning. And I think that's really the make or break for this operation.
Thank you.
Thank you, Dr. Mohammed. Can I ask, please?
Of course.
Yes, kindly regarding for arterial switch, if I have non-facing sinus in the coronary, right. Because I read that I read when I'm preparing for the exam, I read that non-facing sinus, I need either to do arterial switch or coronary grafting, but I didn't get it exactly, to be honest with you. The meaning by non-facing that the bottom will be in the non-coronary sinus, and because of the orientation that I cannot do that can lead to kinking. This is the reason, yani, or this is not true, because you mentioned only intramural. Yes. That need to be a special maneuver to be done. But when I read this, to be honest with you, I review, but I didn't get exactly, I didn't understand it well.
Right. Okay. If you look at this diagram, is it showing?
Yes, yes.
Okay. So you know what's meant by facing sinuses. The classic description of the both trunks is anteroposterior in relationship. Each one of the roots has 3 sinuses. One of the sinuses is further out, and 2 of the sinuses are usually facing the other root. And if you take the first one, for example, which is the normal anatomy, you see that sinus 1 and 2 are the facing sinuses because they are facing the posterior root.
Yes.
And the third sinus, which has no corneostia, that's the non-facing sinus. And if you get a coronary that's originating from a non-facing sinus, it can be more challenging to reimplant. This is more of a problem when you have side-by-side grade vessels, or the relationship is not truly anteroposterior. I must say it's not very common, and there are ways around it. You can mobilize an extensive length of that coronary onto the myocardium, or epicardium, I should say. And that usually gives you enough length to reimplant. But let's say you get in, you examine the anatomy, and you think that this anatomy is not something that you can safely translocate for the coronaries. Then, of course, doing an atrial switch and ending up with a living patient is a lot better than trying to prove a point and do an arterial switch and end up with a sick or a dead patient. So it's good to know that you have bailout options. In some patients, if they have a large VSD, for example, which are often the dwarf type patients with d-TGA or the Taussig-Ming anomalies, these are the patients that end up having unusual orientation of the aortic and pulmonary roots, and they're more on the side-to-side relationship than anteroposterior. If you have a large VSD and you think it's risky to perform coronary translocation, it has been described that you can do a double barrel DKS type of repair and close the VSD to the pulmonary root. So you end up with a double barrel aortic root, and then you have to use a conduit to reestablish RV2PA continuity. So you basically do a DKS Rastelli to get around that problem. But again, I think this is a little bit too advanced for the sake of this presentation and the sake of your training in general. But for people who are interested, there are no limits to your reading and your researching a certain subject. What I'm trying to say is that if you look at most of the contemporary series, coronary arrangement is no longer considered a reason to do an atrial switch, because most of the times you can find a way to deal with the coronaries. But again, never say never. And if the coronary problem is so severe that you cannot deal with it anatomically, then there are other ways to address the problem. So I didn't want to touch on the atrial switch because it's part of the next talk. But if you guys have attended the last meeting of the Congenital Heart Academy online, which was I think 2 weeks ago, yes. Professor Yacoub has quite remarkable work on reviving the atrial switch in late presenters. In Aswan, where he's practicing, I think now partly, he started a program a large program. They perform almost near 100 cases of arterial switch operations a year. And alongside with that, they have a lot of late presenters, sometimes up to the third, fourth decade of untouched patients with transposition. And they're blue and they need something done. And, there is a role for the atrial switch operation. It is a diminishing role compared to, let's say, 3 decades or 4 decades ago. But they still have a role and one of them is unswitchable patients, so to speak. Okay. Mm-hmm. All right, so let's move on. The next part of the presentation is a video. It's broken into 1-minute clips to show the different steps. I have to disclose that these are not my videos. These are from the video library of Dr. Victor Hrashka. I just think that he has a superb quality of video. The video quality is so nice. I couldn't find any better alternative. So if you guys want complete videos of my own, we can find a way maybe later to send them or share them. But for the sake of presentation, I thought these are more appropriate and better in terms of quality. Okay?
Sure.
So here, this is the initial video that shows, is it working?
Yes, it's working.
Okay, so this shows the aorta, sorry, maybe it went too fast. The aorta coming out of the right ventricle, the coronaries, there's a prominent conal branch coming, just under the appendage there. The pulmonary artery is posterior. You can see the takeoff of the RCA. It looks at, in this case, the circumflex is coming from the RCA. But it's a true anteroposterior relationship of the great arteries. I think this is the same. Okay. So next, a marking stitch. I don't do that, but a lot of surgeons do. A marking stitch is inserted where the anticipated site for coronary implantation is going to be, because once the heart is decompressed, it might be difficult to judge. And this is just a depiction showing how the LAD and left button will be translocated to the main pulmonary artery. Once that is done, it's very important to mobilize the pulmonary arteries hilum to hilum, and even sometimes beyond the hilum, to get adequate mobility for the Lecomte maneuver. And it's not necessarily for being able to perform the Lecomte, but it's to prevent undue stretching and stenosis in the branch pulmonary arteries after the Lecomte. The duct is ligated and divided. That also helps with the mobility of the PAs. Now, the patient is on pump, and the aortic root is transected roughly at the s-TGA. And you see in this case, it's a true anteroposterior relationship. The aortic root retracted anteriorly, and then the pulmonary root is divided just below the bifurcation. And it's important to realize that there is not a lot of distance posteriorly on the pulmonary root between the valve and the bifurcation. Now the Lecomte maneuver is performed. The pulmonary bifurcation is brought anterior to the ascending aorta, and the cross clamp is repositioned. Okay, now examining the coronaries and mobilizing the coronary buttons. And this is the part where you have to take your time, assess the anatomy, make sure you're not injuring anything, and you're not detaching the buttons from their corresponding coronaries. In this area here, you're really in a subadventitial dissection plane. Once the button is circumferentially freed, you can use electric cautery for set to low energy for further mobilization. I don't find it really necessary to do extensive mobilization except in cases where the gray arteries are side by side or things are not lined up in a favorable way. Like this dissection in this video, to me, looks a little bit too excessive, but again, it's partly preference. Most important thing is that you don't want any distortion to the coronaries and you don't want too much tension on your anastomosis. Next, the left coronary button, harvested in a similar way. And again, I tend to like to use this kind of scissors. Some people use the POTS scissors, and really just have to be extremely careful. You can see how thin the leaflets are and how close to the bottom of that button. So you have to be really, really careful with these adjacent structures when you're harvesting this button. And this is the type of epicardial dissection that I was talking about that you can do to mobilize the coronary even further. Now, making the holes in the neo-aortic root or the pulmonary root that will receive the coronaries. There are different ways of doing that. Some people just make a slit incision. Some people take a piece of the wall after the slit incision. Others make a punch with an aortic punch that's used for proximal coronary anastomosis. But the most classic traditional way of doing a receiving site for a coronary is the trapdoor. It's popularized by the Australian, New Zealand surgeons, and it gained a lot of, it was received favorably in the community because it does help reducing the tension, and it maintains good alignment with the ostium. And a lot of surgeons still use that technique to this day. I think he's going to do maybe it's just a hole in this one, but yeah. So it's just taking a piece of the wall. This here is an example of a trapdoor or a slit incision. We go all the way to the free margin of the root. So if you look at the left button, it's really just a hole in the root. If you look on the right side, which will follow, it's a V-shaped incision or a J-shaped incision to create a trapdoor. Again, you let the coronaries choose where they want to go. You don't force them to go anywhere. Some surgeons, like myself, I like to start the reconstruction of the aorta partially to have the root fixed and then see where the coronary wants to go. I just find it easier for me to judge it that way. But again, you can do the button relocation and then anastomosis the root. I guess what you're used to doing. And this is just the completion of the coronary button in anastomosis. Maybe we can skip through that a little bit. By the way, I think I haven't discussed sharing this presentation, but please let me know how I can send it to you with the videos so you can keep it for your own records.
Actually, I was about to ask you about this after the lecture, because we have a YouTube channel for our program, and we share all the online lectures we do. But after taking the permission of the presenter.
Well, that's a fantastic idea. I think we should just give courtesy to Dr. Haraska. So I'll just modify this, the beginning of the video part. I'll just mention that these are taken from his video library. And then
yeah, that would be good. And also, Doctor, about the other videos that you mentioned, that your surgeries, if you are also kind enough to share it with us, we can put it also on our channel.
Some of them are on my YouTube channel already, but others are, the only problem is that they're too large, so we have to find a way to share them. But of course, you can have them all.
Thank you very much. We appreciate that.
No problem. So next, the right button is anastomosed. We have 10 minutes left in the talk. We're almost done here. So again, judging where the coronary wants to go, and this is the slit-like incision, so to speak, or a V-shaped incision up to the free margin. It's not uncommon for the right button, not only in arterial switch, but in any root procedure, to want to sit higher than the SCJ. And you'll face that with arterial switch and with other kinds of coronary translocation. And it's important to respect that. Sometimes you have to take it higher than the aortic anastomosis onto the ascending aorta. But again, as long as you're thoughtful about the tension and the orientation, this part should be easily reproducible. Now, of course, after harvesting these buttons, you end up with two big defects in two sinuses of the neopulmonary root, and those are reconstructed with usually autologous pericardial patch, either treated or untreated. It's important to make it generous so that with time and growth, they don't become stenotic. This is a glutaraldehyde treated patch, pantaloon shape, and it's going to be used to fill the defect in the neopulmonary root. I'm not sure what you guys think of the quality of the videos. I think these are some of the best out there. And actually, if you get his book, he describes the setup he uses to take these videos. And it's taken with a high definition thoracoscopic camera that's mounted on a C-arm, not a C-arm, sorry, on a side arm. And you can adjust the angle and the depth, and you don't have to worry about focusing it because it's done by someone else while you're operating. And the more important thing is that your head is not in the way, as in the head-mounted cameras, and there's very little movement, really. So I think these are great educational videos, and I encourage you all, especially the ones interested in congenital heart disease, to buy his video Atlas, which is a book that comes with a DVD in 2 volumes. I can send you the full reference after the presentation. And now re-anastomosing the aortic root with the the neo-aortic root with the ascending aorta posteriorly. Can skip through that a little bit. And again, while you're completing that, you have to pay attention to the coronaries and how much distortion or lack of distortion there is. After that, the pulmonary continuity can be restored with or without a cross-clamp. It looks like he chose to take the cross-clamp off in this case to shorten the ischemia time. And the side branches are controlled with Yazager clips. But you see this patch that was used to fill the defect. It's anastomosis of the bifurcation, which is now anterior to the aorta. And that's it. So that's the final product. You see the PAs nice and mobilized with no real kinks or distortion lying anterior to the aorta. And the near aorta with the translocated coronaries in the back. And that completes an arterial switch operation. Complications, of course, like one of you said, if you have a problem with the myocardial perfusion due to coronary injury or inadequate myocardial protection, you might end up with significant myocardial ischemia and low cardiac output. There could be residual lesions or acquired lesions, such as RVOT obstruction or distortion to the branched pulmonary arteries. And of course, arrhythmias, which quite commonly are a sign of ischemia, but not always. They can be a variety of atrial and ventricular arrhythmias, and they could happen. Late complications, because of the patch that is prone to calcification, you can have suprapulmonary stenosis or branch pulmonary stenosis from the pump maneuver, or calcification that extends to the ostia. As in any conotruncal pathology, the aortic root is prone to dilate. Now, I don't think we really understand the pathophysiology of root dilatation and conotruncal anomalies as well as we think. And the indications of doing anything in the absence of significant valvular pathology or complications such as dissection are not very clear. Most people tend to be more conservative with dilated roots that are from a congenital conotruncal problem compared to as connective tissue diseases like Marfan and Louis Dietz. RVOT obstruction, especially anomalies, they're prone to develop that. And pulmonary hypertension, like you said, in delayed cases are definitely a potential late complication. I think this concludes my my presentation. I hope I managed to cover most of the relevant subjects pertaining to arterial switch operation for simple d-TGA or d-TGA with no associated problems, which was the goal of this talk. As you can imagine, it's a large subject with a lot of relevant topics that we can talk about, but I think for the sake of this lecture, as long as you know it's a cyanotic neonatal problem, how to deal with it initially, the non-surgical management, and the main principles of the surgical management, you have it covered. Any questions?
Any questions, guys?
Yeah, I have a question, if you don't mind. Dr. Shihata?
Yes.
Yeah, regarding mobilizing the coronaries, you were saying that it might be too extensive in the video or unnecessary, or sometimes only minimal mobilization is enough. And as you said earlier, that the coronaries are the most important part of this surgery, taking care of the coronaries. So what is the cutoff for the mobilizing the coronaries? Is it the first branch, or is it like specific measurement? If you have.
I honestly don't know the answer to that question. I think every case is different. In general, I tend to mobilize less unless I really have to. I just worry that the axial distortion, the risk for axial distortion will be higher if you mobilize too much. However, as I said, sometimes you're forced to mobilize in order to get a tension-free anastomosis. So yeah, it really varies from one case to the other. I don't think there is a general rule about the first branch. I know that's mentioned in some references, but really depends on the underlying anatomy.
Thank you.
Conditioning of the LV for later presenters using PA band and
yeah, I think I'm 6 years into practice and I've only had to do it twice. And for both cases, I kept them in-house, short-term band for 2 weeks, and then assessment by echo, and take them back for the arterial switch. We didn't have to put any of them on ECMO, but that's an acceptable risk that you have to consider if the LV is not still fully trained. Now, whether these will ever return to be normal systemic ventricles is, in my opinion, unlikely, but they will be strong enough to sustain systemic circulations. There is evidence that really late presenters after 5 to 7 years, depending on which report you read, even if you train them by high pressure, they never go back to a normal systemic ventricle. They're always have microscars and they don't become normal. But the concept, I think, is one of the most genius things that have been introduced by Dr. Magdi Yaqub, and it has been reproducible. Some people use a shunt with the band. I would say it's like a 50-50 need. I personally haven't in my 2 cases, but I know some cases require shunting to maintain adequate saturation and for volume loading the systemic ventricle. But yeah, it's something that is not done very commonly in the country anymore, because we have a number of centers that can do this neonatal surgeries, but in places where they don't have quick access, it might still be a real challenge, and you might have to do it more than you think.
Yeah.
Is the question clear to the rest of the group? The elaboration, I guess.
Please, doctor.
Okay. Which area is not clear? The whole concept?
I mean the concept of preconditioning the ventricles and so on. I don't understand the concept of this.
Okay. So the left ventricle in d-TGA is a subpulmonary ventricle. It's connected to the pulmonary artery. And even though after birth, the SVR and PVR, which is the systemic vascular resistance and pulmonary vascular resistance, are almost equal, shortly after birth, the PVR drops significantly, and the LV, which is supposed to be the systemic ventricle, is exposed to lower pressure. And just like people who work out, if you work out a lot, you get bigger muscles, unlike me. And if you're exposed to low pressure, then the muscle thickness and the strength of the ventricle becomes less. So if you are to subject a deconditioned or a weaker ventricle, even if it's an anatomically left ventricle, to systemic circulation, all of a sudden, it may not do very well. And you might end up with a dilated cardiomyopathy kind of situation. So in order to regain some of that strength, the training of the left ventricle for the purpose of a future switch is by banding the PA, applying a band so that you achieve a near systemic pressure in the pulmonary ventricle and it's not supporting cardiac output, so it's okay. It will struggle for a little bit, and then it will become thicker and stronger to a point where you hopefully can perform an arterial switch operation. If you have to do the band too tight to get the desired end result, then you might have to add a BT shunt as a source of pulmonary blood flow, just for the interim until you do the full repair. Yeah, so that's the concept of LV training.
Thank you, clear.
Doctor, I have one question regarding the d-TGA with the VSC and pulmonary stenosis. What's the best procedure for that in terms of outcome and the complications?
Yeah, again, that's an advanced, good question. All three are supposedly serving the same purpose: the Rastelli, the Nikaido, and the REV, or the REV. Now, some people argue that the colaminar outflow and that could be potentially superior and carries less risk of future LVOT obstruction. Again, it's a subject of debate even in most recent meetings. I don't think, personally, I don't think any of them is superior to the other. It's actually dictated sometimes by the underlying anatomy. If the VSD is somewhat restrictive and somewhat remote, I think an Nikaido operation is better. But if the VSD is large enough or can be enlarged safely to an adequate size, I really don't think there's a difference. And of course, people who try to avoid conduits do that to avoid the complication of conduits. And again, that's an ongoing debate between the European school and the North American school. But I'm not sure I can label one of them more superior. But my default procedure in this diagnosis is a Rastelli operation with or without a VSD enlargement.
Oh, okay. Okay. Thank you.
You're welcome.